Hi, I'm Dr. Jonathan Fenkel. I'm the director of the Jefferson Hepatitis C Center here in Philadelphia. There's never been a better time to be diagnosed with hepatitis C and to be seen for your hepatitis C. We have great treatment options available today, and if you go back even just 4 or 5 years, it's amazing how we've gone from a treatment that lasted 48 weeks with shots every week and 12 to 18 pills a day to treatment options that generally have 1 pill a day for most patients and range from as short as 8 weeks to as long as 24 weeks with cure rates over 95%. Most patients that walk in the door can be treated successfully these days. In the past, many patients had contraindications of being treated. They had other conditions that may not have lended well to the treatment options at that time. Pretty much everyone that walks in the door could be treated successfully if you have a few pieces of information. Really, we need to know what their genotype is, what their viral load starts at, as well as whether or not they have cirrhosis. With that, looking over their medication list, we can usually draft a successful treatment regimen for them. The biggest challenge really isn't the medicine anymore. The biggest challenge is getting the medicine approved. So sometimes we spend more time getting medications approved than we do actually with the patient in the office. Many payers are getting a little bit better this year about approving treatment. But because of the cost of treatment, we're seeing a lot of restricted access to patients with more advanced liver disease. We have to stage their fibrosis either with a FibroScan or a blood test called a FibroSure. And so it takes a little while to get the medicine in the patient's hands, but once they do, it's very successful. I do see patients with HIV Hep C co-infection. In the past, we had to be a little careful to make sure the antiretroviral regimen didn't interfere with the hepatitis C regimen and vice versa. But with the current treatment options, we don't usually have to adjust the antivirals for their HIV, and most patients can be treated just like anyone who didn't have HIV. I think I would just encourage, for the primary doctors, encourage screening. Don't forget that anyone born between 1945 and 1965 ought to be tested for Hep C at least one time. And don't forget to ask the hard questions about risk factors for Hep C in patients you're concerned about. You don't have to be judgmental about it, and just help the patient understand that this is a treatable condition, and we're here to help and get rid of your virus so you don't have to worry about cirrhosis, liver failure, or liver cancer in the future. There are many good treatment options right now, and oftentimes we'll see a patient who comes into the office asking for a specific medication by name because they've seen it advertised. And that medication may be a great choice for them, or it may not be, depending on their genotype or whether or not they have cirrhosis. I'm pretty confident we'll be able to cure that patient with whatever we can get for them approved. And a lot of times the treatment choice isn't always mine or theirs. A lot of times the payer is a big part of the discussion there. There's new data coming out every day on hepatitis C. Every hepatitis meeting or liver meeting or infectious disease meeting, we see hundreds to thousands of new articles and abstracts presented. I view it as my job to stay on top of that literature at running the Hepatitis C Center. I think that's very important. Our societies have our back on this, where the American Association for the Study of Liver Disease as well as the Infectious Diseases Society of America have joined together to publish online guidelines at hcvguidelines.org that are updated very frequently. They're great resources for treating providers, not only to keep up to date with the literature, but to help your patients access those medications with up-to-date references.